Yeah, the CALLA trial, it was remarkable in the sense it's a large global prospective double-blinded placebo-controlled randomized trial in patients with high-risk cervical cancer. And we chose this high-risk cervical cancer subgroup because these patients really constitute an unmet medical need. They have historical recurrences of more than 50%. And so there's a high percentage in terms of desired enrollment for stage 3, stage 4, node positive patients, both pelvic node positive and periortic node positive. And so it was a large global trial that took 770 patients and randomized them to the addition of Durvalumab concurrently and sequentially to chemoradiation versus chemoradiation alone. Our findings were that, number one, CALLA is one of the largest global trials in cervical cancer to date. And we had more than 120 sites, over 15 countries participating. And we had a remarkable number of patients who were of Hispanic origin. So 45% from Latino, Latin America were enrolled on the CALLA trial. So it's truly global and remarkable in that regard. In terms of the subset analysis, we looked at high-risk patients in terms of periortic node disease, pelvic node disease, as well as those patients who had the number of cycles of chemotherapy. The majority of patients received more than 4 cycles of chemotherapy. 95% of patients received brachytherapy, which is almost unheard of in terms of a global response to brachytherapy. And that was really because we had a very robust radiation quality assurance and control on the CALLA trial. We had a global radiation therapy steering committee. I was chair of that committee. We met regularly. We discussed the cases. We also reviewed the external beam plans. We looked at the brachytherapy plans within 1 week of therapy, and it was extremely robust. If a patient had a deviation in terms of the steering committee thought that there was something that could have been improved upon for the external beam plan or brachytherapy, the site was given feedback in a timely manner. And actually, if a patient was not going to receive brachytherapy, we had to know. And myself as the PI on the study and the radiation study chair, I actually personally contacted those sites, and we were able to convert several patients back to brachytherapy. In terms of the impact of Durvalumab, we found that radiotherapy, external beam, chemotherapy, and brachytherapy were able to be given in a timely fashion, as well as in a complete fashion. And the impact of Durvalumab did not change that. Durvalumab in and of itself did not increase progression-free survivals between the arms based on subgroup analysis. So at this point, our conclusions are that high-risk, node-positive, or locally advanced cervical cancer treated with the technologically advanced chemoradiation and brachytherapy did as well as those patients who received the Durvalumab arm. So the CALLA trial was really remarkable in terms of setting a new benchmark for global radiation therapy quality assurance and control and technology. I will note that more than 85% of patients on this trial received IMRT, and a very high percentage, more than 2/3, were treated with image-guided brachytherapy. And also within the CALLA baseline characteristics, we found that the PD-L1 status on these patients, as determined by the tumor area probability score, was greater than or equal to 1% in greater than 91% of patients, greater than 5%, and about 77 to 81% of the patients based on the arm. This is very high. Again, in terms of the progression-free survivals, at 12 months, we found no difference in the arms between the addition of Durvalumab versus placebo. Durvalumab and chemoradiation had a 76% 1-year progression-free survival, and the placebo arm had a 73%. At 2 years, that dropped. However, there was again no difference. 66% in the Durvalumab arm, 62% in placebo chemoradiation arm with a p-value of 0.174, a hazard ratio of 0.84. The maturity and the follow-up is about 18 months on this study, with the maturity being 31%.